From the plains to the rolling hills, Oklahoma is a state that resonates with stories of resilience, determination, and pride. Welcome to Inside the 1581, a podcast of the Oklahoma Hospital Association. Together, we'll dive deep into the heartbeat of the great state of Oklahoma as we journey through the rich history, diverse culture, and the ever-evolving landscape within the 1,581 miles of border in our nation's 20th largest state. Each episode of Inside the 1581 will feature conversations with the many voices which help shape our state's future and our shared vision of improving health and healthcare in Oklahoma.
The Harry S. Truman Library at Independence, Missouri is the scene of an historic event. President and Mrs. Johnson and Vice President Humphrey arrive for ceremonies that will make the Medicare bill a part of Social Security coverage. Mr. Johnson chose to sign the bill here as a tribute to former President Truman. The former president campaigned for Medicare 20 years ago, but it took 2 decades for his proposal to become law. The new bill expands the 30-year-old Social Security program to provide hospital care, nursing home care, home nursing service, and outpatient treatment for those over 65. Medicare will become law on July 1st, 1966, and for Mr. Truman, an historic souvenir from the president. For Mr. Truman, the passage of Medicare is a dream come true.
Welcome to this edition of Inside the 1581. I'm Rich Rasmussen. I'm your host, and you were just listening to, and of course, if you were on our YouTube site, you saw the historic signing of the 1964 Medicaid law that was signed by President Johnson, who incidentally won the state of Oklahoma by an 11% margin. I'm not sure we've had a president other than maybe Ronald Reagan that won with a margin. Maybe President Trump did by 11%. I'm not sure. But certainly President Johnson was very popular. And one of the things that he really pushed hard on was the creation of Medicare and Medicaid. And that bill was signed in Independence, Missouri, with President Truman, who was the first to offer up a national health insurance solution to really support our seniors as they were aging, and certainly our aged and disabled members of our population or our communities. And so that's coming up on its 60th anniversary here this July. And we thought we would lead with that as we begin our conversation in this episode of Inside the 1581, talking about SoonerCare here in Oklahoma. And I am delighted to be here with the CEO of the Oklahoma Healthcare Authority, Ellen Buettner. And Ellen, welcome.
Thank you. Happy to be here.
And you know, she's dressed in green. You're just a couple days late. You know, that was the one thing. I had very little green that day, and everyone kept pinching me here in the office. But Ellen is here to kind of just give us a little bit of some background on SoonerCare, certainly SoonerSelect, what the differences are. And here at the Oklahoma Hospital Association, you know, one of our stated goals is to improve health and healthcare, and access is a big part of that. And so Ellen and her team are the ones that are leading our access initiatives through Medicaid. And Ellen, thank you. And tell us about yourself, because I think I wanted to ask this question. Do I get to call you, when I walk up to you, do I get to say, "What's up, Doc"? Because I know you work on your PhD too, or did you already get it?
I did the PhD about 5 years ago.
So now I can say, "What's up, Doc"?
You can say, "What's up, Doc"?
Okay, all right. I always love doing that. I have physicians in my family. Whenever I walk up to them, I get popped in the head when I say that to them. So, but tell us about yourself. You've been a career public servant, and you've been at the Healthcare Authority. You've been in other state agencies. I believe you are the secretary, or that explain to our listeners about your role in the governor's cabinet. I think that would be very interesting for folks.
Yeah, absolutely. Well, first of all, thanks for the invitation to be on with you all. Hospital Association's always been an amazing partner to the Healthcare Authority, and especially as we have transitioned the past 3, 4, 5 years through expansion, through the managed care transition. You all have just been incredible partners. So I want to say thank you for that, and thanks for having me on. Like you said, I've been a career public servant. I started my career at the Department of Mental Health and Substance Abuse Services back in 2008 as a baby attorney. My first job out of law school.
That was before PhD.
Before, that was pre-PhD.
I'm going to tease you about that now for some time to come. But go ahead. I interrupted you.
So my joke is to people, there's no reason they should have hired me. I had no experience in state government, no experience in mental health care or anything like that, fresh out of law school, but they took a chance on me. And I've had some just incredible mentors that have helped me throughout my career journey. I spent a little over a decade at the Department of Mental Health and Substance Abuse Services, legal for a while, learned the operations side from an HR standpoint, from a program integrity standpoint, and then really got interested in the policy side of things. Started going over to the Capitol, getting to meet some folks over there, and one of the things I really loved about being in a role like that was the ability to collaborate with others, public-private partnerships, interagency partnerships to really drive health outcomes and make a difference in Oklahoma. And so that really became a passion of mine. I spent a brief stint at the Attorney General's office about around the time that they were working really closely on opioid abatement projects, as well as criminal justice reform projects, where you saw that intersection between the criminal justice world and public safety, but also a really big healthcare focus. And then after that, went over to the Healthcare Authority as chief of staff, did that for 4 years, and then I've been sitting in this role for about a year and a half.
So this was like a job interview.
Yeah, exactly.
Well, thank you.
Should have just handed you my resume.
Well, there you go. Well, again, thank you for your advocacy on behalf of all of us in your team's advocacy. And I think folks probably don't have an appreciation for what the Healthcare Authority does. Maybe you can kind of share with us, the different, I would argue, different service lines, focus areas, what have you, so that we get a real good flavor of how big you are, what you're doing, and then we can get into the role as the insurer for our vulnerable populations.
Yeah, absolutely. So, most of your listeners, I imagine, are familiar with Medicaid, broadly speaking, but much like Broad Medicaid celebrated their anniversary recently. Healthcare Authority recently celebrated our 30-year anniversary as a state agency administering Medicaid in Oklahoma. So OHCA, in partnership with other state agencies, primarily the Department of Human Services, the Department of Mental Health and Substance Abuse Services, OHCA serves as the single state Medicaid agency that provides healthcare insurance services to children, low-income adults, pregnant women, and our age-blind and disabled population. Those eligibility requirements hinge largely on income eligibility criteria. So it's a state-federal partnership, so we don't do this alone. We have an incredible provider network of around 80,000 providers that actually administer those medical services to the people that we serve.
And we think providers, everything from dentists or physical therapists through hospitals, nursing homes.
Behavioral health, primary care practitioners, all over the state. So we have certain network adequacy requirements that we have to meet with CMS. So
pause for someone who doesn't know what CMS is, Centers for Medicare and Medicaid Services.
Centers for Medicare and Medicaid
really
Services.
they oversee these programs because they are a federal partner in it.
Correct.
Okay.
So CMS is our federal partner in this. They set largely the requirements concerning funding, qualification guidelines, quality metrics, and the like. And so those things are routinely monitored and audited by CMS. But then CMS also gives states the flexibility in how they administer their program really outside of those core requirements. So there's for example, mandated set of covered benefits from the feds that each state is required to cover. And after that, states have the opportunity to select optional services that they feel are going to make a difference in their communities. So every state's program looks a little bit different.
And so for one of our optional programs, certainly pharmaceuticals is an optional program, the ability to expand coverage for pregnant moms and babies. So we've gone, I believe it's 185%, and we went to 210%.
We went up to
205. We have support in the background. I have that too, so it's great. But 205%. Okay, so that really, when you look at it, for children, we almost have universal health care coverage between what someone would receive if they have employer-owned or individual health insurance plus the combination of Medicaid.
Right. So there's a lot of opportunities in Oklahoma to obtain Medicaid coverage, especially if you're a low-income individual. So we have the Medicaid program. We have exchange programs that are run through the insurance department. So yeah, absolutely, a lot of opportunities to get coverage.
And having that coverage, certainly for moms and babies, we have better outcomes. Obviously, it does help our state overall in terms of our performance and how we perform in our healthcare. And I think for employers who are looking. They want to be able to relocate to healthy communities, and I think that's a big part of it. Now, it's interesting. Almost 1 in 4 Oklahomans is on Medicaid.
Right.
So you couple that with probably 50% of our patient days for hospitals on Medicare. So you look at this state and federal partnership, feds on Medicare, feds and state on Medicaid, is significant in terms of what that means for us. And so for you all, managing such a large program, you don't do it all on your own. You guys have now looked at ways to bringing in some private resources through managed Medicaid organizations. Tell us a little bit about that and give us some background on what SoonerSelect is actually delivering and what that means, because I think like next week is the one-year anniversary.
Yeah,
There you go.
April 1.
So-
April 1. Yeah, we hit early on our dental one-year anniversary. We started that a couple of months early to try to just get that one off the ground a little bit quicker while we worked on medical. So, we talked just a minute ago about the mandatory services and certain requirements that CMS puts on us. And so one of the big goals of moving to a managed care environment really was geared towards how do we really help people both in the doctor's office, in the hospital, in the behavioral health clinic, in the dentist chair, but how do we also help them outside of those situations, meaning addressing the social determinants of health that might be having a long-term impact on their healthcare outcomes, especially in rural communities. This is something that's really important to us. So under CMS guidelines, Medicaid agencies from a state perspective have some sort of limitations in what we can actually cover outside of medically necessary services. And so what we're able to do in a managed care environment is partner with these private insurance companies to administer the same core set of healthcare benefits that the Healthcare Authority has covered for years, but they also have that flexibility under a per capita cap model to provide opportunities for more community involvement, education, food insecurity, helping people maintain employment, getting assistance within the criminal justice system for individuals that might be involved and having that as an impediment to their overall economic success and healthcare success. And so really that was the impetus towards wanting to move towards managed care, is to really address those overall quality metrics that we want to see in Oklahoma.
So for managed Medicaid, it's only on our expansion and essentially our OB population.
Expansion, pregnant women, and children.
Okay.
Right.
And so the expansion, first for our listeners, if you're not familiar, was part of a constitutional initiative that was passed in 2022?
2020.
2020.
Implemented in 2021.
And so that has allowed individuals up to 138% of the federal poverty level to be covered. Essentially, we're probably talking, I don't have my FPL numbers here right in front of me, $18,000 a year, $19,000 a year for an individual. So it has been significant with about 300,000 people within this population. And so you've taken the experience, the discipline of private healthcare insurance companies to come in and manage this population for you. And so walk me through how you arrived at the decision. And certainly you went through a process to select these organizations that are doing that. Kind of for listeners, explain to them the thought process behind why we're doing this. For me, I look at it as an opportunity to have some accountability in terms of how we match in our Medicaid enrollees with their primary care physicians, bird dogging their health care, making sure they're getting healthcare services earlier in the episode of their disease so that we can avoid costs. Because, I was pulling a number just a minute ago, and it was fascinating to me when we look at the incidence of disease. So across the country, we spend about 2.1% of our overall expenditures on healthcare for pregnant births, pregnancy and births. But for cardiovascular disease, almost 11%. So here you have these chronic conditions that if we spend more time focusing in on, and so I look at managed Medicaid as an opportunity to bring some of that discipline to bear and accountability on the health plans too, to help address some of these chronic conditions. So thoughts on that and how you guys arrived at this and how the rollout is working?
Yeah, definitely. So I can probably take you back 3 or 4 years. It was
Perfect.
definitely a multi-year process with a lot of stakeholders at the table in developing this. And so I briefly mentioned one of our goals just in terms of addressing social determinants of health and really that whole person care. And really, as we started diving into it and looking at the successes and areas for improvement in other states that had done this, Oklahoma
and
was...
everyone's subject to improvement. That's what we should be doing. Continuous
absolutely.
improvement's important.
You know, Oklahoma was one of the last states to move to a managed care model, and so we had the benefit of being able to research what's worked well in other states and what we could do better. So really, we pulled together a pretty extensive stakeholder group. Hospital Association was at the table, legislative partners, the governor's office, primary care groups. So we had physicians at the table, behavioral health folks, to really talk through, okay, in an ideal world, what would this look like? We don't have to do it like every single other state does. What's going to work well in Oklahoma? And so we worked together in partnership with the legislature to design Senate Bill 1337, which was the authorizing legislation that directed the Healthcare Authority to move towards a managed care model. And so within that legislation, there were certain guardrails, provider protection guardrails that are put into place around things like timely payments, timely prior authorization, turnaround times. And
which other states played catch up trying to make those changes. So you took advantage of coming in later to the game to make those market adjustments before they became issues.
Right, right, exactly. And then another big piece of that you've already alluded to is around this idea of a renewed focus, I would say, on preventive and primary care. And so we put into the legislation a requirement that within 4 years of implementation, so we're almost 1 year in now, as you mentioned, within 4 years of implementation, we would have each plan's medical spend 11% beyond primary care. So to put that into context, right now the Healthcare Authority, our percent spent on primary care is about 5.5%. So pretty lofty goal. And one of the ways that we hope that we will get there are through certain care coordination efforts and, of course, leveraging the experience that some of these plans have in that regard with connecting them initially with a primary care provider to hope that we can get those folks in early. But also providing certain incentives to providers, both on the physician side, the hospital side, behavioral health, to really incentivize providers to make that connection with the people that they're serving to get them in the door early and often so they can address some of those issues before they become more chronic.
So if we have hospitals that are in underserved communities, where we probably think that the numbers of enrollment in SoonerSelect, as an example, should be higher, what resources are available to them through the Healthcare Authority? So if they if they wanted to be able to offer that enrollment opportunity in a small hospital, and let's just pick one in Cimarron County, I mean, what resources are available to them if they said, hey, we want to take a bigger role in trying to enroll our community members in healthcare coverage?
So we have quite a few agency enrollment partners where people can actually work with a provider on site or someone in their office who is able to do that. So absolutely, we can enroll people on site that you see that are eligible for Medicaid generally. You can do that. And then we also have a very robust call center and team that works through both the eligibility side, but also on the care navigation side when we have open enrollment where individuals can sign up for the plans that really help them identify which plan is going to be the best for them. So you may have a family that has a child that would really benefit from a from a certain value add that one of the plans has, because they're all going to have the same basic coverage, but we really want to help identify those plans that are going to meet the core needs of their family.
Absolutely. So if we look at, so we're talking just a little bit here about SoonerSelect, that is the expansion population, pregnant women and children, through a managed Medicaid model using commercial HMOs. So essentially, they're managing the program, you're paying the bills. You're paying three organizations to do that. So it does create some administrative simplicity. But on the other side of the ledger, you have a population ostensibly made up of the aged and disabled. So these are folks that might be needing special at-home care. They may need skilled nursing care. So if you look at that population, how much does that differ from the SoonerSelect population?
Yeah, that's a great question. I think certainly you're going to see different risk areas with that population. What we're working on right now, once we launched managed care and started working through that implementation process, we didn't want this age-blind and disabled population to not also get the benefit of some sort of healthcare reform, because we need to do better in that regard too. So what we've been looking at is a redesign of a patient-centered medical home idea to serve this age-blind and disabled population, really looking at who are our highest utilizers, who are our highest cost members, and really the most in need. These are individuals that might have severe healthcare issues coupled with behavioral healthcare issues. And so we're trying to figure out the best way to really attack that so that we're wrapping the services around these people that they really need. And so that's in flight. But absolutely, it's a different care coordination approach with that population than it would be in the expansion adult population.
Well, as a son of a 95-year-old mom who is now starting to consume healthcare, it's amazing. She's not on any medications or anything until now. Not on medications, but might need some skilled care here in the near future. But trying to navigate and find resources for your 95-year-old mom in Florida, right, a $50 billion Medicaid program, it's incredibly difficult to find out, where other resources, and particularly if you pay out of pocket for, if you're not on Medicaid, where they are. How do you integrate them? If you're an MA plan, how does that work? If you're in a traditional Medicare, how does that work? I'll tell you, it is very difficult. So, helping to offer those resources to help family members, to keep their family members independent, I think is really important. So as you guys look forward to how you're going to serve this population, I just encourage you to continue to look for those ways to provide those navigation services, because it's really difficult.
Yeah, absolutely. No, I think we definitely need some innovative approaches, especially as we, especially in the next decade or two, we're going to see an influx of population and folks that need that level of nursing home care. And so it's a balance of making sure that we have an adequate network of quality care providers for folks that really need to be in a nursing facility, or you may have others, like your mother who do very well at home, may just need some other certain supports. And so we have a waiver program right now where we offer certain supports to keep people in the home who it's safe and healthy for them to be in the home.
Well, maybe we can talk a little bit about that when we come back from our break.
Sure, absolutely.
So we're going to take a break here inside the 1581. Been delighted to be joined by Ellen Buettner, who is the CEO of the Oklahoma Healthcare Authority. We've been talking about Medicaid, our Sooner Care, our SoonerSelect population, our aged, blind, and disabled population, all as we come up pretty soon here on the 60th anniversary of the creation of Medicare and Medicaid. But before we come back, we're going to listen to a quick message from our sponsors at Forefront Healthcare. Looking to elevate your support services? Forefront Healthcare is a leading provider of food, environmental services, and facility management to hospitals all across the country, and was recently recognized as a 2023 Top 100 Best Places to Work by Modern Healthcare magazine. So to learn more about Forefront Healthcare and how they can help elevate your patient, staff, and family experience at your facility, visit forefronthealthcare.com or call 1-800-684-6450. Welcome back to this edition of Inside the 1581. I'm Rich Rasmussen, and I'm joined here with Ellen Buettner, who is the CEO of the Oklahoma Healthcare Authority, and we've been talking about Sooner Care. And so for those of you who may have missed the opening of our show today, we've been talking about the one-year anniversary of SoonerSelect, which is the managed Medicaid part of our Medicaid system here in the state. And we started to get in a little bit on to Medicaid's role in supporting long-term care. And so we can pick up with that.
Yeah, absolutely,
Ellen?
Absolutely. Well, first, I'm noticing my lovely coffee mug here.
The coffee
so
mug.
How did we come up with the 1581?
Well,
I've been sitting here trying
first.
to figure that one out.
That's a good one. So inside the 1581, we're like, gosh, we're going to do this podcast. We want to just talk about different stories. And so here we're talking about Medicaid, but we've also talked about the NBA game. Alex, remember about what canceled it because of COVID. So we talked to the team physician of the Thunder. We've talked about food insecurity, human trafficking, So it's not always about hospitals. And so we're like, what are we going to call this thing? So we were sitting here spitballing. And so I just Googled how many miles of border is there inside the state of Oklahoma? Well, there's 1,581.
Okay.
So we're inside the 1581.
Fascinating.
So that's how we came up with it.
Great.
Yeah.
I love it.
Yeah. So it sticks. And we also have a really good audio guy that makes it all sound really good here, right, Alex? And and a really good voiceover in the beginning of the show. So, and special prize if you can guess where the voiceover is on other commercials that you will watch on TV tonight.
Okay.
So there you go. You guys listen.
I'm going to pay attention.
Yeah. But let's get back to our questions. So we talked a little bit about long-term care, and I expressed, my mom being at 95 and might need some skilled nursing here in the future. So we're preparing for that. So if you're a family member here in Oklahoma, and you might be in that same boat, you're trying to make sure that your parents or your grandparents, if they needed Medicaid coverage for nursing home, what is the process you go through? Because I know we're working with a couple different agencies, and so how does that work?
Right. No, I think that's a really great question and something that's important for your listeners and Oklahomans in general to know. So we do partner largely with other state agencies to administer certain portions of the Medicaid program. The Department of Human Services serves as our main partner when we start talking about things like eligibility for nursing level care. So you can reach out to them. You can go by one of their county offices. There's phone, and they would help walk you through that.
Do they have a website so you can begin enrollment online?
Right. So you could go through their website. So there's a lot of entry points to be able to meet that eligibility criteria. There are some additional documentation requirements than you might see if you are, say, an expansion adult applying. They're going to be looking at asset verifications and things like that in order to be eligible for nursing facility. But once you go through that process and work through that with DHS and you get that notification from DHS that you are eligible, that's something you could then share with the nursing facility so that they know that you have that level of coverage.
And so for our listeners, it gives you the opportunity to provide some information based on your income. So if it's Social Security, railroad retirement, U.S. Postal Service, what have you, any of your expenses, that it runs a formula and it determines whether you're eligible for that. And so if it's determined you're eligible, now I know that I have Medicaid coverage to pay for skilled nursing. Now, what do I do with that? Do I take that to the nursing home? How would that typically work, do you think?
Right. So we have a really extensive network of nursing facilities across Oklahoma, some in rural parts of the state, but some in very rural parts of the state. And so typically you're going to find those within your community that you can figure out the best situation for your family. So you go, you can visit with them. They have a couple of associations as well that represent that provider group that can provide some resources to allow you to navigate that system.
Well, it is one in which, we don't plan for, but it is something that I think for folks to recognize that, if there is a need for your family, there are resources. And that kind of gets me to a point too, when we look at our state, and I think oftentimes folks feel as if, wow, there's no opportunity for me to receive healthcare coverage. So help me walk through some of this. So we've got Medicaid, or the Sooner Care. So we have aged, disabled, and seniors, blind and seniors. We've got the working population through expansion. We've got pregnant moms and babies if they meet the eligibility criteria. We've got nationally, we have healthcare premium assistance for folks, which we have about 300,000 on that, equal for the most part to what we have in Medicaid expansion. We have a Healthy Kids style programs. We've got a pretty robust network to support folks who need health insurance.
Right.
And so it sometimes confounds me that we don't have more people taking advantage of that. So are you aware, is there any one place that you can land at that we can be driving folks to see all of the coverage availability? Or if you're not aware of anything, how does that work at OHCA? Do you have a typical landing page that people can go and see what's available for them?
Yeah, absolutely. So I can speak from the OHCA angle. We have an eligibility landing page. You have your own member portal that you're able to submit documents, talk to our call center, work through any sort of questions, whether that be around eligibility, whether that be around your service coverage. So there's quite a few opportunities from that side on the healthcare authority side where we have that dedicated resource for folks. But you bring up an interesting question, one that we've been talking about quite a bit. When you look at the numbers, we have a lot of opportunity for healthcare coverage. We have really an incredible network of providers, be that hospital systems, local providers in their own local clinics, behavioral health providers, FQHCs. We have a lot of opportunities for people to really take the reins on their own healthcare. And so I think where we need to do a better job is how do we connect people with those resources, knowing what your coverage is, whether you are covered by one of the exchange plans, Medicare, whether you have an MA plan, Medicaid, understanding what providers are in your coverage network and making sure that you're getting connected with the right people and the right resources. And that's where I think a lot of these public-private partnerships that we talk about really come into play, especially when we talk about balancing the primary care healthcare that people so desperately need, having hospital availability for those emergency situations, inpatient situations, where hospitals provide incredible care to people. But also then how do we make sure that people are being taken care of when they step outside the actual hospital setting or the physician's office? How do we make sure that they have healthy food available to them? How do we make sure that they have safe shelter available to them? And so that's one of the areas where, especially within the managed care environment, but then also just some of our additional conversations with stakeholders, including hospital association, on a regional approach to how we really make sure that we're targeting our resources to get the best return on our investment for the people that we're serving.
Well, certainly when somebody discharges and they have those post-discharge instructions, making sure they do that. And so food is a part of it, certainly. Post-surgical site maintenance is important, that people are looking at, their surgical site, making sure it's not getting infected. They're making those calls. They follow up again in the appropriate number of days. And so hopefully, when we look at the discipline that managed care can bring to this, coupled with the provider community, hopefully that will allow us to show or demonstrate that it's working.
Right, absolutely.
And so we're 1 year into this. So we have potential risk factors that are hanging out there. We've talked a little bit about this. And I say the risk factors are, if Congress decides that they're going to move forward on cuts, and we don't know, they may or may not. So we're kind of dealing with an unknown, but let's say they did. We could find ourselves, if the federal government changed the rules in terms of what their share of this partnership looks like, it could mean that our state would have to come up with some additional resources to pay for our Medicaid program, particularly the expansion population. And so there's a uniqueness to Oklahoma, unlike, I think, every other state, in the fact that our expansion is enshrined in our Constitution.
Right.
And so the only way you could unwind that would be to pass another constitutional amendment. Right. And so it does complicate it, unlike other states. And so, you're sitting in this seat thinking, I don't upend what we've got, because I think what we've got is working. Right. And I think we've turned a corner in this state.
I agree.
In terms of health performance and supporting our rural communities. The 28 or 23 vulnerable hospitals are surviving because of the work you guys are doing through our Medicaid program. So kind of walk me through kind of your thoughts about how this could unwind, and hopefully, we all hope it doesn't unwind, because it is something that's really, it is really serving, our neighbors.
Yeah. So, that's a big question. So I'll start with what you've already mentioned around the risks around expansion funding. Sure. I think that's something a lot of folks have seen in the news and things that have been said and proposed at the federal level on an informal basis. We haven't actually seen any specific proposals around it, but one of the things that was floating out there is this idea of changing the FMAP, which is that the federal share.
So for folks that are listening on the Medicaid expansion population, federal government pays 90% of the cost. The state pays 10%. And of that 10%, the hospital tax or hospital fee pays a big chunk of that.
Right.
Yeah.
Right.
And so if we receive less federal funds, then we have to have state funds to make up for it.
Exactly. So as you mentioned, expansion is in the Constitution. There are about 12 other states that have it in statute that have what they call trigger laws, where
Right.
if there's any sort of shift in the federal funding, they have the option to modify their program as they see fit to make it work within their state budget. Oklahoma's a little different in that we have expansion as well as these specific eligibility requirements actually enshrined in the Constitution. So when you started hearing numbers being thrown around as to what the potential cuts could be, we started looking into that. So if there's a shift from 90% federal match to about a 60% federal match, and so the state has
Is that
to,
our current match rate, FMAP, right now for
so
traditional Medicaid?
we're around 66%.
That's what I thought. Okay.
In our traditional match rate. So taking it to 66%, what we would see is our traditional match rate that, as you know, fluctuates from year to year. It was around a $450 million potential impact that the state would have to make up to maintain those services. If it went all the way down to 600, it's more like a $580 million impact. We have in Oklahoma what I'll call a Medicaid rainy day fund. It's called the Rate Preservation Fund. At the end of this fiscal year, there should be close to about $600 million in that. And really the goal of that fund was to protect against provider rate cuts, make sure that we can maintain the services that providers can offer and offer them that support in situations where there's a bad budget year or there is a significant shift in the FMAP, and we need to support our provider community in that regard. So we do have somewhat of a safety net, but if you think about numbers as large as if they actually go down to
Well, and that's only a
60%,
1-year safety net, right? So
exactly.
it doesn't give
That would be wiped out almost immediately. So, there may need to be a discussion amongst lawyers about how it all plays out in terms of the expansion and Constitution and what the options are. But just generally speaking, if you're just looking at the hard numbers, that's really what we'd be looking at.
Well, it's like the old saying that when the legislature is making laws, it's like making sausage. This would be really messy sausage.
It would be very messy sausage.
When you think about it.
Yes.
But let's hope we don't have to go there, right? Because I think the promise that we have in our state is really getting us to a place better than our 47th national ranking.
Right.
And that's really not a fair number for healthcare because there are pieces in those national rankings that really aren't healthcare related.
Totally agree.
So you look at some of the things that we're doing well, maternal child health, we do pretty well on. There are a number of those. But an area that I think has really benefited from expansion, we don't often talk about it, and I think you have some experience in this, and that is behavioral health. I mean, we look at the number of folks that now have access to behavioral health services that without expansion, they really didn't. And we've seen the impact that it has had in terms of getting services to somebody really early in the episode of their addiction or any other mental illness that they're dealing with. Your thoughts on that and what you've seen in terms of maybe there's some transformation we're seeing in people's lives because of that, the access to behavioral health services.
Yeah, and I think that's a great point. And one of the biggest things that we've seen really in the last decade or two is really a reduction in the stigma around accessing mental health care, right? People aren't afraid anymore to go.
And they shouldn't be.
They shouldn't be. They shouldn't be. Afraid to go get treatment. There's also some innovative approaches that Oklahoma has taken advantage of. We have an incredible network of both inpatient providers in the behavioral health space, but also outpatient providers, and really trying to focus on this idea of integrating primary care, behavioral health care, and treating that whole person. Community mental health centers are a great example of where people can go and receive that type of behavioral health care, but also understanding what resources are available to them in the community. So I think Oklahoma was honestly really on the forefront of investing in some of those innovative opportunities in terms of crisis access care, partnerships with law enforcement so that people are seeing a behavioral health provider instead of ending up in a jail cell or in the back of a police squad car. So there's been some incredible partnerships and innovations there that Oklahoma, I really believe, has been on the forefront of.
Well, and that's something we should celebrate when we have successes like that. When we look forward, we lean in. I talk to staff all the time. We need to lean in on these things. So if we look forward on, the real opportunities for us, if you could pick, say, 3 things that if you could harness all of your energy that you would like to see changed or improved, 3 things within, let's use SoonerSelect since it's coming up in your anniversary. what would those three things be? And is there a call out to other stakeholders to help you achieve that?
Mm-hmm. Wow, that is a really great question.
And we don't always think about it, right? We look at what's in front of us.
Right.
And so let me give you one that's in the back of my mind all the time. And that is how we can spend more time educating folks about the availability of coverage.
Mm-hmm.
Because one of the indicators on the national health rankings is the number of people who have a primary care physician.
Mm-hmm.
And I would hope that between 50% on average people covered under Medicare, 20%, 25% on Medicaid, 3/4 of our population ought to be able to know who their primary care physician
Mm-hmm.
is. If we can get to that place, that helps us on rankings as one example. So just some thoughts.
Yeah, absolutely.
Because these are kind of the quality measures maybe we talk about too,
Yeah. I think that understanding what your coverage is and what you have access to, I think it's also getting back to not just necessarily being quote unquote assigned a primary care provider, but actually building a relationship with that primary care provider, having someone that you trust, especially in rural parts of the state or certain minority communities. What some research shows is there's a lack of trust in the healthcare system, and so I think rebuilding that trust in terms of understanding what's available to you, understanding that your provider has your best interest in mind in terms of your overall healthcare. I think that's one way that we're really going to make a difference on the front end of things. In terms of quality metrics that we're looking at, we're really focused on addressing some of these chronic conditions. Oklahoma has a very high rate of diabetes, and so investing in opportunities around reducing the obesity rate, medication management for individuals, that's going to be a big piece of what we can focus on. In addition to maternal health outcomes, I think especially in certain parts of the state, we have a shortage of OB providers. And unfortunately, budget constraints. Certain hospitals have had to close their OB clinics, which really prevents access in certain situations, or I will say prevents local access for individuals. And so I think getting to a place where we can figure out a way to support providers so that they have that physical availability to be there for people, but really educating the patient, the Medicaid member on the importance of that prenatal care, the importance of going to those appointments, the importance of abstaining from drugs and alcohol, and really helping from an educational perspective, helping people make their own healthy choices about what's going to make a difference for them.
Well, I appreciate those comments because I know talking to our hospital leadership across the state, they're excited about being able to address some of these. And it wouldn't be possible without what we've done with SoonerSelect and Managed Medicaid. And for those who may not be in our field that are listening, we have a really unique program in the state called a directed payment program. And so that program allows a hospital to be reimbursed, and we also utilize this to leverage this for our physician community as well. Right. Allows a hospital to use part of the hospital fee that funds Medicaid expansion to use it to draw down additional federal funds and to kind of bring the payment reimbursement rates closer to what the private sector would pay. And that has been a godsend to hospitals, particularly our small hospitals. So to your point about, having obstetrical deserts, we now have hospitals that are talking about bringing OB back because it can be sustainable again. Right. And so without that additional resources, it would likely result in closure of hospitals. And we know there's about 23 hospitals that from a metric perspective are at risk, but what's keeping them solvent and keeping them alive is the work you guys have done to help create this directed payment program. And so I would be remiss if I didn't say thank you, because you guys helped craft that. You worked with the Hospital Association. Last year you worked with us on gap funding to jumpstart it, to keep these hospitals open. And now I truly believe we have sustainability in place. And we have the opportunity to grow beyond sustainability. And that wouldn't be possible without this. And so thank you to you guys. And I just put it in the back of your mind. That's the one thing, that we worry about that, along with Medicaid expansion going away and any budget cuts, because it would devastate rural communities.
Right. Well, and I appreciate you saying that. And, you all have been amazing partners in the development of this program. At the end of the day, I firmly believe we're all Oklahomans.
100%.
We all have the same goals. And
even an old Florida boy is now an Oklahoman.
We'll take you.
Yeah,
we'll adopt you. But, I think Oklahoma's a really incredible place. You have people at the state level, at the local community level, and everywhere in between that truly want this to be a great place for people to live. I think everyone knows our health outcomes are not acceptable. And you're seeing more and more, or at least I have been, more and more coalition building just around how do we align and support each other instead of competing with each other to really help people be the best that they can be. But you're absolutely right on the supplemental payments. So, just to kind of set the baseline on it, historically we had what's called a supplemental hospital offset payment program that was designed really in partnership with the hospital association. That provided, I would say, rate gap funding between the Medicaid rate and the Medicare rate. So as you mentioned, one of the other positive byproducts of moving to a managed care environment is that we could move to this directed payment, which allowed us the opportunity to fund the gap between Medicaid and 90% of the average commercial rates. So that brought in about an additional $700 million into Oklahoma on top of what the hospitals were already receiving for that gap between Medicaid and Medicare.
And I think it's a real recognition, too, of how low rates were.
Right.
You got to get them up there. And Oklahoma's not, on its own. I mean, every state has historically over time, the payment rates have significantly eroded over time.
Right.
So you're not alone.
Right, exactly.
So, in the states I've been in, it's always been a big issue for us.
Exactly. Exactly. Well, and one of the other things that's cool about the program, especially the new provider incentive program, is they're tied to quality metrics and quality outcomes. And so providers have some skin in the game as well in terms of receiving some of those extra incentive payments. But all in all, to your point, 90% average commercial rate isn't even average commercial rate. So we still have a ways to go just in terms of the recognition of what's needed.
Well, it has been the seed corn that is keeping communities alive. I'll close with this. We've talked about this staff before, and there's this old story about early cartography. So cartographers back in the day drew our maps. And back in the days when they're drawing it in the 17th century, 18th century, we didn't really have copyright laws. And so when they would draw a map, they would put the name of a fictional town on that map. And that fictional town was designed so that if the next person drew a map and they copied you and they had your fictional town on it, you could claim ownership over it, that they copied you, right? And so when I look at our small towns, what I don't want to see 5 years from now is that these towns lose their local critical access hospital, or they lose their local PPS hospital. And because of that, the town dries up and they become nothing more than a paper town. And so my hope is that we don't evolve into that. And so as we go forward, and that'll be part of our messaging to the general public, is that when we think about any potential cuts or disruption or change in our system, we've calibrated it right now for success. And any slight deviation from that does put at risk countless communities across the state. And I have visited them all the way from Boise City all the way to Idabel, and every community between in the last 2 years I've been here. And there's some great stuff going on. And I just hope that we continue to focus in on doing more great stuff. And I want to thank you, Ellen, for being here, the Healthcare Authority for being partners with all the provider community on this. And you've been listening to this edition of Inside the 1581. We have Ellen Buettner, who is the CEO of the Oklahoma Healthcare Authority, who her and her team help lead the financing of healthcare coverage all across the state through our Sooner Care programs. And it's just been a delight to spend some time with you. I will always say, "What's up, Doc?" now. So be prepared for that when I come around the corner. Those of you who didn't understand that, listen to the beginning of the story. So as we wrap up, I just want to say thank you for joining us for this edition of Inside the 1581. And I hope you've enjoyed our episode. Before we go, I want to give a huge thank you to Forefront Healthcare for being our sponsor today. I did wear their bling. See that, Alex? I wore that just to promote them as well. They're good partners for us. They provide food service, environmental services for our hospitals, and they've been a longstanding supporter of OHA and the mission that we're on to improve health and healthcare. And part of that, I want to thank Alex Taylor, who is producing this and makes this happen, and our Vice President of Strategic Communications, Susie Wallace, who helps coordinate everything that we're doing. Be sure that you subscribe and follow us and stay up to date. You can do that through Spotify or through YouTube or through Apple Podcasts. Also want to mention today that our music, as always, is provided by Ends of the Earth, and it's their title track, Gunslinger. We appreciate them allowing us to use their music. Until then, thank you for joining us in this episode of Inside the 1581, and we'll talk to you again soon.